Hello, everyone. Welcome to our webinar, Shared Vision, Caring for Your Glaucoma. My name is Michelle Elizalde, and I am the Director of Patient and Research Programs at Glaucoma Research Foundation. As you've probably heard, January is National Glaucoma Awareness Month. It is a good time to talk about this sight-stealing disease and raise awareness about the importance of regular eye examinations to preserve your vision. So talk to your family and friends about glaucoma. Do your part and help us spread the word. Glaucoma Research Foundation is proud to once again partner with Bausch & Lomb to advance patient education and awareness through your national campaign, Your Eyes Say Thanks. Together, we're working to inform, inspire, and empower those affected by glaucoma. To help accelerate discovery, Bausch & Lomb is matching all gifts to GRF up to $20,000. So your generosity can go twice as far this January. Please consider making a gift today and doubling your impact for glaucoma research. Okay, and today we have two amazing doctors from Vance Thompson Vision joining us. We have Dr. John Berdahl, a board-certified ophthalmologist and internationally recognized corneal, cataract, glaucoma, and refractive surgeon based in South Dakota. Dr. Berdahl received his medical degree from Mayo Medical School, completed his ophthalmology residency at Duke University, and pursued advanced fellowship training at Minnesota Eye Consultants. Ranked among the top 2% of ophthalmologists worldwide, and he has contributed extensively to research and innovation in glaucoma care. His clinical expertise and scientific leadership and commitment to advancing patient outcomes make him a distinguished voice in the field. And I'm also so pleased to welcome Dr. Justin Schweitzer, a fellowship-trained optometrist focused on advanced glaucoma care, refractive surgical clinical care, and anterior segment pathology. Dr. Schweitzer earned his Doctor of Optometry degree from Pacific University College of Optometry and completed advanced training in glaucoma and anterior segment disease after joining Vance Thompson Vision. He is a nationally recognized educator and currently serves as Chief Medical Editor for Modern Optometry. His leadership in integrated eye care and ongoing contributions to glaucoma education make him a highly respected voice in the field. So please join me in welcoming John and Justin.
All right. Thanks, Michelle. Everybody, Michelle is just one of the really good people in our profession, and there's so many great ones. And speaking of good people, I get to do this with my good friend and partner in our eye business, Justin Schweitzer. We work together every day. We were seeing patients together less than an hour ago. In fact, one of our most difficult patients, and difficult in the sense with really difficult glaucoma. And so we're excited to be here. We're based in Sioux Falls, South Dakota. There is no snow on the ground. It's a balmy 42 degrees, and we're inside because we love educating about glaucoma so much. So let's dive into it. And for those of you in the audience, what we're going to really do is just kind of go through the X's and O's and the basics of glaucoma. And then we're going to open it up to questions, and we're going to answer those questions in a real way, just like you're our patient sitting in front of us, and tell you what we would want you to know. Usually Justin's the substance guy and I'm the color guy, but we're switching it up this time. And so I'll be running the slides and Justin will be adding the color commentary, and this is really for you. So we're grateful that you've given us your time, and hopefully we can make it worth the gift of time that you've given us. Okay, so what is glaucoma? And this is a bigger question. It is something that we don't really know the fundamentals of the disease. I actually have some very strong opinions on it, but here's what we do know. It's a progressive disease. Once the damage is done, you can't undo it. It damages these little cells called retinal ganglion cells. So what you're looking at on your right is a picture of the optic nerve as it enters the back of the eye. That's that yellow piece. And then those are some blood vessels coming out of the optic nerve. That optic nerve in our back of our eye is 1.5 millimeters in diameter, and it has 1.5 million little fibers coming through it. So think of it like a fiber optic cable, and it splays out and becomes the retina that senses light. And those little fibers die one by one. And that's what glaucoma is. It's usually associated with an elevated intraocular pressure. So that's the pressure inside your eyeball. And we know that something about that pressure causes those individual ganglion cells to die. And oftentimes we think about this as a balance between how much fluid the eye produces and how much fluid the eye drains. And that's true for what causes the intraocular pressure. But it's not true that just because you have a high intraocular pressure, you'll get glaucoma. Or if you have a low intraocular pressure, you won't get glaucoma. Justin, fill in some gaps for me.
I think that is, the puzzle of glaucoma. I mean, when we talk to other doctors, when we talk to patients, intraocular pressure is the thing that we always talk about and we think about. It's the one modifiable thing, but I really like to think about it like a big puzzle. And we know that there's more to it. It's not just intraocular pressure, and we're going to talk about a little bit of that here in a second. And we also know that this question's a big one. Who can get glaucoma? Well, anyone can. Really, anyone can get glaucoma. And that's really the challenging piece of the disease, is that a lot of times people that do get it don't know they have it.
Yeah, that's right. And one of the things that we've really dove deep on and are probably, some of the leaders around it is whether or not brain pressure matters alongside of eye pressure. Because that optic nerve that we talked about, what its job does is it's to transmit signals from the eye to the brain. And it goes through two pressurized regions, the intraocular space and the intracranial space, the brain space. So I really do believe in my heart of hearts that glaucoma is a disease where there's a higher eye pressure and a lower intracranial pressure. And that can explain why some people that have normal eye pressures don't end up with glaucoma. So who gets glaucoma? Like Justin said, uh, anybody can get glaucoma, but there's some risk factors. There's at least 3 million people in the United States that have glaucoma. So that's over 1% of the population. It's more common as you get older. It's the second leading cause of blindness in the world and the top cause of irreversible blindness. So now, if you're a patient and you're on here and you just got diagnosed with glaucoma, that can be really a scary thing to hear. And what I want you to know is that almost always, if you're good at seeing your doctor and they're good about taking your glaucoma seriously and know what they're doing, almost always we can prevent blindness. Okay. So there's varying types of glaucoma that are difficult to treat, but you are developing a relationship with your glaucoma doctor. And if you do your part and they do their part, I don't want you to have unnecessary fear of blindness. When doctors cause unnecessary anxiety, we didn't do our job right. We need to be sitting right next to you, partnering on this thing. Most people, is this is a real problem. Most people that have glaucoma don't know they have it. And we'll show you why in a little bit. Especially in the Latino community, especially in communities that don't do a great job of getting excellent access to doctors in their care. It's 8 times more common in people of African origin. And by 2030, it's a growing condition, probably primarily because of the aging population. And so, I like this picture. There's all sorts of different types of people here. And, the eyes, when you look at this picture, the eyes stay the same, but the people are different. And it's not just about the eyes, it's about the person behind them, behind those eyes. What we need to do is what's in the best interest of your life. So here's risk factors. I'm going to run through these quick. If you're older, you're more likely to get it. If you got family history, you're more likely to get it. If you have something weird going on in your eye, you're more likely to get it. If you have high eye pressure, if you've had trauma in the past, some medications, I wouldn't worry about that too much. If you're African, Asian, or Hispanic, you have a higher increase. And if you're very farsighted or very nearsighted, And what I want you to hear more than anything else is none of these are the primary driver, except for maybe high eye pressure. So if you're older, doesn't mean you're going to get it. If you're African American, you're still probably not going to get it. But the other thing I want you to hear is you can have none of these things and still get it. They're just risk factors, and there's only one way to know, and that's to work with your eye doctor. Justin?
Yeah, and I think, the family history part is a big key for me. You mentioned this, that you know, patients that have people that are on the call today that have moms, dads, brothers, sisters that have gone blind from glaucoma. I'm much more worried about those people than I am people that have moms, dads, sisters, brothers that just have glaucoma. To me, it's two different types of glaucoma.
Yep. And I'm hoping my slide's going to advance here.
John, I wanted to add something else as you're doing
Yeah,
that. You
good.
said earlier what you wanted patients on here to hear and know about glaucoma. I think if there's anything good about the disease, and this isn't all the time, and there's nothing good necessarily about it, it's that traditionally most types of glaucoma are slow moving. And so if we can get it caught, if we can find it, we can typically slow it down. It's not an acute, quick blinding disease, which is much different than some other eye conditions that we deal with. Now we know that there are cases where glaucoma can be fast moving and we can have acute loss of vision, but many times, and you'll hear us say it multiple times, going in and listening to your provider when they want you to come in is so important. Having yearly eye exams, if you don't have glaucoma, is so important because if we do catch it, I really believe we have enough options in our arsenal that we're able to really manage the condition. And if we have something in our favor, it's typically slower moving.
Great. Well, I pushed the forward button so many times when it wasn't moving forward that we're done. Thanks everybody for being with us today. I'm just kidding. I'll get back to the slides I need to get back to. And it's just going to take us a quick second here. Sorry about that. It's just a little delay from pushing it. Everybody gets a no surprise reveals in this talk.
Yeah, if we ask questions now, you're going to know the answers. That's for sure.
That's right. Okay, so how is glaucoma diagnosed? Who gets glaucoma? What are the signs and symptoms? Real quick, what a symptom is something you feel. What a sign is something that we look at. You won't be able to tell if you have, lower contrast sensitivity. Color vision probably doesn't change a lot. But here's what basically, you're not going to know. If you look over at that picture on the left, that's normal vision. If you look over at that picture on the right, that's late bad glaucoma that's taking your peripheral vision. And what I want you to notice is that you don't even can't even really tell those things on on the sides. The brain doesn't create a dark spot that you would notice. The brain just fills in stuff when there's missing information. And so you can't know if you have glaucoma. We have to look at you. And that's the biggest driver of why we want people to get regular eye exams over age 40. So when you come in and see us, we're going to do all of these things that end in Y. Gonioscopy, pachymetry, tonometry, perimetry, photography, tomography, ophthalmoscopy, all these letters that weren't meant to make words, but we're going to tell you a little bit about what they are and why we're doing them. So gonioscopy is first. What this really is we're looking with a mirror into the drainage angle of the eye. So where the colored part meets the white part of your eye, we're looking to see how open is it or how closed is it. In the United States, it's almost always open. In other parts of the world, it's more common for it to be narrow, but it's an important thing for us to look at because it starts to put us down one treatment algorithm versus another. What does a patient need to know about gonioscopy, Justin? Not much.
Yeah, not a lot. I think it goes back to what I mentioned earlier. If there is a fast-moving, blinding type of glaucoma that can happen acutely and quickly, it's when the angle's closed. And that's why your doctor's doing it to make sure that that angle's open, which traditionally it is. And then it's typically a slower moving type of glaucoma.
You almost certainly, if you're in the United States, have open angle glaucoma. And one question that we get a lot is, hey, this cold medicine says don't take this cold medicine if I've got glaucoma. If you have open angle glaucoma, you can. If you got narrow angle glaucoma, you're taking some risk. That risk is low, but some risk. But if you got open angle glaucoma, don't worry about it. Okay, pachymetry, another word that wasn't meant to, letters that wasn't meant to make a word. Pachymetry is used to measure the thickness of your cornea. The cornea is the clear part of your eye where you put a contact lens. Justin, why does this matter?
Risk assessment, in my opinion, if you have a thin cornea less than 555, there was a large study done on this. That means you're at higher risk to develop glaucoma. You're at more risk for glaucoma.
Tonometry means what is your intraocular pressure? You will hear us slip into IOP, intraocular pressure. No, quote, normal pressure is between 12 and 21. But again, if your eye pressure is higher than that, doesn't mean you've got glaucoma. And your eye pressure can be 13 and you can have glaucoma and be getting worse. It varies. It goes up at night. And we generally like to see a 30% reduction in your eye pressure, 20 to 30% reduction in your eye pressure from where you were at when your glaucoma was progressing. So if you came in at a pressure of 20 and you were getting worse, 20% of that is 4. So 20 minus 4 is 16. We'd probably like to see you at 16. Some doctors set target or goal pressures. Others just think about this because it's not really about a number. It's about what pressure is safe for you. Justin, what do you want people to know about their eye pressure?
I just think that it's the one thing that patients and doctors fixate on too much. It's modifiable, it's important. We need to know it, we have to measure it, but we care more about what's happening with this test and the visual field test. We're going to manage the IOP, but you can't necessarily fix on it because if you have glaucoma, you don't have a normal eye pressure. It doesn't matter where it's at. We need to find the eye pressure that's ideal for you to stabilize the OCT in the visual field, which we're going to talk about next.
Yeah, great. So OCT, optical coherence tomography. This is like a CT. I think you can think of this as like a CT scan of your eye that's very high resolution. It doesn't use X-rays. It uses optical light, but it can help us objectively look at damage in the visual field or in the optic nerve, so know where problems are at. Justin, does their eye doctor need to have an OCT?
In my opinion, now, yes, I think that to catch
I agree.
glaucoma earlier, and even as the disease progresses, you have to have an OCT to manage glaucoma appropriately.
Take home point is if your doctor doesn't do this test, you're not with the right doctor. Okay, visual field. Oh, here's what an OCT looks like. You don't really need to know any of this. What if you look at that image over on the left and you see that circle? That's where it's measuring the thickness of your optic nerve, and we're looking to see if that thickness is appropriate or if you're starting to lose those little individual ganglion cell fibers we talked about at the beginning in one area or not. Photography, we can take pictures of the back of the nerve. This is less important than it used to be. I don't think that you need to have something like this. An OCT, an exam, and a visual field is important, pretty obvious what it is. But man, I never get tired of looking at these pictures. It's like looking back into a world that nobody else gets to see but allows us to see. So this is the only place in the body where you can actually visualize the central nervous system, where you can actually look directly at blood vessels and directly at neural tissue and see so many things about people's lives. It's the window to the soul and it's the window to their health, high blood pressure, low blood pressure, diabetes, other things. And so the one on the left is healthy. You can see that that bright yellow spot is pretty small in the center of it. Over on the right picture, you can see that that yellow spot is enlarged, and that's called cupping, and that happens from probably an elevated pressure or a pressure differential. Visual field tests, these things are miserable to
No
do.
one likes these.
Nobody likes
I
these.
wish we had a polling question we could put on here right now. Who likes to
Yeah.
take a visual field?
Well, we can
That's
ask
on the
each other,
call.
Justin. Do you like these?
Oh, I don't, I mean, no, no one likes
Neither.
them. I don't like them all,
100% of
but we
people
need
in our
them.
poll did not like them, but we do need them. This measures the function of your eye. What is your visual field like? And so, guys, here's what I want you to hear. This test is designed by the Swedes to trick you. They want you to push the button when you're not supposed to and not push the button when you're supposed to. And I'm not kidding because it makes noises like it should show you a light and you're trying to say, did I see that light or not? All designed to try and get a high quality test. And you can't use the other cues. Just look and see if you see it or if you don't. If you see it, push it. If you don't push it. Justin?
Yeah, I agree. I think that out of all the tests we do, this one is overthought of and at times can be inaccurate because we're overthinking it. So, as you said, get in there, push the button. Thankfully, they've made some changes to these perimetries, and you that are taking them know that they're a lot faster than they used to be. At times, they take 13 to 16 minutes. Now we see them as fast as 2 to 4 minutes.
This is what a normal visual field looks like. Do you see that black dot on there? That's your where your optic nerve enters the eye because there's no retina tissue there. You can't see. That's also known as your blind spot. So that's normal. And then you can see that there's no damage anywhere else. When you look at this, this is the progression of glaucoma or different glaucomatous types of visual fields. And so you can see every one of them has that optic nerve, that blind spot that we saw before, but then you start to see loss of vision in other places. And guys, I hope what you're getting out of this is there is a lot of pieces of the puzzle to glaucoma. It's not just an eye pressure, it's not just a visual field, it's not just an OCT or corneal thickness. All these things have to correlate together. But let's zoom out a little bit more. Just like Justin said, it's not just about your IOP, it's also not just about your visual field, it's about your life. And it's easy for us as eye doctors to forget there's a human attached to that eyeball, a human that has to try and put in eye drops, or a human that has red eyes or from taking medications, or a human that, it's hard for them to get to the doctor to go to and have surgery or something like that. And so our first place where we start is saying what's best for the eye. Then we zoom out and we say, what's best for this person? And if you're a 47-year-old active young woman and have glaucoma, your treatments are going to be different than a 97-year-old person that, has a cancer and that's gonna get them because we have decades of vision to preserve in one and maybe months of vision to preserve in another one. And so it really is individualized based on who you are as a human being. And this is kind of how the visual field affects your actual life. There is a whole bunch of glaucoma medications, and you think those other letters weren't meant to make words? How about aproclonidine or brimonidine or levobunolol? Don't worry too much about these things unless you're taking them. What I want you to know is that the GRF has a great website and it tells you about these medications and what they are and what they do. And we don't have time to go through all of them, but you should ask and understand with your doctor, what medication am I using and why am I using this? And less we're using medications as first line, and more we're doing laser treatments. So this is what's going to be on the quiz at the end for you. So just take a quick look at this and then we'll ask you exactly what you should do in every situation. This is what we need to understand, okay? What you want your doctor to be able to do is be facile with all the options. They need to understand the different treatments, whether they're surgical, medical, lasers, OPAP, all of the things that are out there now. And then we need to be able to be facile enough to put the right technology for you, not force you into the technology that we have. And there's so many options, and the options are so much better than we used to have. Okay, there's some words that we use that are kind of weird. Justin, a glaucoma suspect. What's that?
So that's someone that has risk factors, a thin cornea. They may have a slightly elevated IOP, above that normal range we saw earlier, normal of 21, but they don't have a visual field defect and they have a normal OCT. And so nothing that we can technically diagnose them, but they're at risk for it.
Yep. And how we follow your glaucoma is really dependent on how bad that glaucoma is and how confident we are that it's stable. If you have, if we're just checking you and you think you might have glaucoma, we'll probably bring you back in a year. If you got stable glaucoma, we might bring you back in a year, maybe twice a year. If you got glaucoma that's getting worse, we might become really good friends and see every 6 weeks. So it can range. Now, here's another thing, and this can be a little controversial, and it's sad that it is because optometrists and ophthalmologists have a common goal, and that's to take care of your eyes. But occasionally we get in pissing contests with each other, and we say, one is better than the other, or, an optometrist may hold on to patients too long, or an ophthalmologist may not allow a patient to see an optometrist that is doing a great job for them because we're human beings and we get frustrated with each other sometimes. You don't allow yourself to get caught in the middle of that. Okay. If you're with a doctor that's not able to collaborate with a specialist, or if you're with a specialist that's not able to collaborate with somebody that you're working with, don't allow yourselves to get caught in the middle of it. And frankly, it doesn't happen nearly as much as it used to. And Justin and I, he's an optometrist, I'm an ophthalmologist, and I would trust Justin with my eyeballs every day, and I hope vice versa. And so just know that everybody has your best interest at heart, but once in a while the humanness that we have can get in the way of making your care as convenient as it can and it should be. So now let's close on this, living with glaucoma. So you get told you have glaucoma, and like I said at the beginning, it can be scary. If you take only one thing away from this talk today, just one, it's that very, very likely, if you see your eye doctor and your eye doctor's doing a good job taking care of you, you will live a sighted life for all of your life. We may have to add medications, may have to add surgeries, but you probably will. And that's what I want you to walk away from it. But I also want you to hear this: you got to do your part. You got to see your doctor, you got to do what they say. And if you can't do what they say, then you need to tell them that you're not taking your drops or you're not doing your thing so we can adjust. So work with your doctor, be well informed, follow up, tell us what's going on. And if you modify your life, usually just a little, you're going to end up being sighted all your life. Justin?
Something you said earlier that is so important is the communication between the doctor and the patient. I think you said vision is the first thing that we care about. We want to protect your vision. And what sometimes takes a second seat to that is the quality of life pieces. And that is so important for you on the call that are patients to communicate with your doctors if a drop's bothering you or you're not taking it. I would hope, and I know I would never, and I know you would never ever judge based off a patient telling me they're not taking their drops. There's a reason they're not doing it. And my job then is to find something to allow the treatment to work, whether that be a surgery with you or a drug delivery device with you, John. And so I think that communication is so critical. It's not all about stopping vision loss. It's also about you living a good quality of life. And at times that doesn't always happen.
Yeah, that's right. All right, let's go into the Q&A. This is the best part of it, right? And so we didn't come here to answer the easy questions. I mean, you can ask us easy ones, but we came here for the hard questions. So ask the hard questions, or put us on the spot. Call us out if you think that something we said isn't right. Let's get into it and get real about it.
Well,
So
first of all,
yeah.
thank you for that great presentation. You guys explained everything beautifully, and we've received lots and lots of questions. So I'll just jump right in.
Well, then we
Uh,
maybe didn't explain things that beautifully. If there's lots and
no,
lots of them, here we
no.
go. Let's do it.
Quite the opposite. You explain it well, and then it spurs curiosity and more
Ah,
questions.
great.
So someone said, one of my doctors recommended laser surgery, and another doctor asked me not to do laser surgery. What should I do?
Almost certainly the doctor that recommended laser surgery is right, I think. Um, you know, Not able to tell for sure if that's the case. without, seeing the eye exam, but the odds are much more in the favor that laser surgery is the right early or first move. Justin?
Yeah, I would agree. I mean, it depends a little on the type of glaucoma, maybe the type of laser. If it was SLT, then that to me seems like that would be the right move. There's other lasers that are maybe a little more invasive, but if it's SLT, I agree. It's got to be, it's likely the right move.
Thank you. Can you explain a little bit more what you meant by modifying our lifestyles?
Yeah, Justin, you go first and I'll go second on modifying your lifestyle.
Well, I think, number one is the communication thing I kind of ranted on at the end. Lifestyle to me is also quality of life. So, communicate with your doctors. If you're miserable taking an eye drop because it's bothering your eyes and it's uncomfortable, that's a lifestyle modification, but you can't modify that yourself. You have to communicate with your doctor. And then I would say too that there is data and studies, and there's plenty of this out there looking at diet and what you're eating. And we know that a diet in high nitrates, so leafy green vegetables, has been shown to help our patients that or any of you with glaucoma. And so just thinking about that as well would be another lifestyle modification. John?
Yeah, so I agree with everything that you said, Justin. There's also some data around meditation or deep breathing that can help with IOP and stuff like that. And it turns out that makes those things make your life better in other ways too. What I what this comes down to the philosophy that doctors have sometimes. I believe the fewer days that you're in our clinic, the more you're living your life. And my job is to help you live your life. And you should be able to do the things that you want to do in your life. So don't stop doing the things that you want to do in your life. And so I'm not a big, I mean, don't smoke. Okay. That's not good for you. And it's not good for your glaucoma or your eyes. But there's some data that says caffeine maybe makes eye pressure go up a little bit, or some others that says it goes, have a cup of coffee if you love a cup of coffee. Don't don't make your life miserable because it just maybe might help with some study in mice or whatever it is. Live your life and then talk with your doctor about the things that you're worried about that maybe you don't want to give up.
I feel like I need to give you a t-shirt that says keep calm and live your life. And then you just wear that when you see your patients.
Keep calm, live life, see your glaucoma doctor once in a while.
Yes. Okay, on to the next question. Can you explain OCT again, and how does that test help manage our glaucoma?
Yes. Justin, go for it.
Yeah, sure. So you described it really well earlier with the MRI analogy. That's really what we're doing. We're taking an MRI or a scan of all those fibers that are coming out of the nerve. And so early in the disease process, you're not going to have a visual field defect. Your vision's going to be completely normal. But what the OCT can do is it can pick up very early thinning of those cells, damage of those fibers that are coming out of there. And so we utilize it to identify glaucoma early. And we know patterns from tons of research that's been on that, where we look at it and that's a glaucomatous pattern of thinning that we see. And so it's really allowed us to catch the disease process earlier, intervene earlier with safe, effective things, and hopefully get out in front of it. Because once the boulder's rolling down the hill and it's rolling fast, it's a lot harder to treat it. So having an OCT and getting out in front of it early, we can stop that boulder from rolling down the hill quickly.
I gotta believe with the few hundred people that we have on here, there's a super nerd on there. And for them, the physics basis of the OCT is the Michelson interferometer. And if you like to geek out on that stuff, that's what was used to help determine the speed of light. And then we use it in OCT. So there you go.
Very cool. Thank you. Along the lines of diagnosis is who takes care of the eye pressure checks and glaucoma eye drops and glasses at different points of the glaucoma care?
So basically, which type of doctor is going to be in charge of glaucoma at
Yeah.
different points? Is that how you're reading that question?
Yeah.
Yeah, I think that most initial glaucoma, I would say that the vast majority of it probably now, maybe north of 70%, is diagnosed by an optometrist the first time. Because that's where most regular eye exams are in, and then they check a pressure and it's high, or an OCT and it looks, or the nerve looks a little funny. And so in our practice, there's an optometrist and an ophthalmologist involved in everybody's care. We're the subspecialists and the optometrists in the community, take care of things day to day. And if the glaucoma seems like it's getting worse, they let us know, but then we see them back on regular checks. And so I would think about it like this: early in the glaucoma, most of it can be optometry or an ophthalmologist. Late in the glaucoma, you need to have an ophthalmologist at least involved and aware of what's going on. Justin, do you see it any differently?
No, and just because late in the disease, there's probably going to need to be surgical intervention. And so you want to be collaborating back and forth.
Yep. Yep. I
That's
agree with that.
great. And when you have a team-based glaucoma care, um, well, if you have it in like different locations, because you work together in the same office, but if you have people, an optometrist in one office and a glaucoma specialist in another office, the providers, they should be sharing all the information and coordinating correctly. I mean, or how does
Yeah,
that
that's yeah, yeah,
usually
yeah.
work
That's typical. And just like most humans, doctors aren't perfect at communicating either. And so
out?
um one of the things that I think is great is if you get a printout of your exam when you're
Mm,
with the doctor, ask for one. If you know your next appointment's going to be with your ophthalmologist and you're with your optometrist, or vice versa, and then you don't get to the doctor's office and they say, "Oh, they didn't send me the records." Well, hey, great, no problem. Here you go. I'm carrying it to you, and I think that that's really good. I also think a real fair question to ask your doctor is, especially if you're seeing your regular eye doctor, is at what stage do you start to become uncomfortable with glaucoma? Because
mm.
some of them are going to be very comfortable and very good. Look, you can see Justin Schweitzer for however bad glaucoma you have. He's going to make the right call and refer it for surgery if it's needed. And there's others that might be a little bit more timid, and I think that it's important for you to understand that.
Thank you. Jumping a little bit is generally how many years does a trabeculectomy and shunts last in eyes after surgery? Is it true that blebs cannot be removed to replace with a new one?
Justin,
Yeah,
you go and I'll add color.
yeah,
What a
yeah.
fun question.
Yeah, yeah, and I'm going to take it. I'm going to stick with the data and the studies around this. So with tubes and trabs, there was a large study that was done looking at the longevity of them and how they work. And so tube shunts, on average, about 30% of them will fail at 5 years, and trabeculectomies, about 50% of them will fail at about 5 years. Now that doesn't mean they can't last longer than that. I have plenty of patients that John has done tubes on that are well beyond that and doing just fine and doing very, very well. But that's what the data would say along tubes and trabs. John?
Completely agree. And you can't just replace a bleb. The bleb is really where the fluid is flowing to. And so think of the bleb as a blister, and that fluid is flowing into the blister and then diffusing out. And we want to do everything we can to avoid messing with that bleb if we can, because once it starts to fail, it gets more difficult.
Got it. Can glaucoma affect ocular cataracts even with surgery?
Yes, glaucoma can cause cataracts, and it's not really the glaucoma itself that causes the cataract. It's some of the surgical interventions that we do. Trabeculectomy increases the rate of cataracts, peripheral iridotomies as well, tube shunts, and don't be scared of cataracts. Cataracts are easy to fix, so don't not do a glaucoma surgery because you're worried that you can get a cataract. Justin?
Yeah, doing cataract surgery is one of the best glaucoma surgeries there is. It's another
Yeah,
reason
that's
not to
right.
be scared of a cataract. Get that out.
And you see better.
My parents had it a few years ago and they're very, very happy that they had cataract surgery.
That's something to look forward to with age is cataracts. It's great. You get younger.
Can you explain, I guess, the pros and cons of MIGS surgery and while having cataract surgery?
Yeah. Yeah, I have a strong opinion on this. I think that the pros outweigh the cons by a mile here. And primarily because it's so safe. So there's different MIGS procedures. There's stents. There's removing some of the trabecular meshwork. And the risk is really, really low. They work pretty well. They're not as aggressive as other things. It might not get you there, but if it doesn't get you there, it didn't hurt you, and it gets a lot of people there. So if you have glaucoma and cataract, and your glaucoma's mild or moderate, maybe even severe, but mild or moderate for sure, you should not have cataract surgery alone. You should have cataract surgery with a MIGS. Justin?
Completely agree. And I feel like I'm the study guy right now, spitting out studies. That's not usually my thing. But
Whatever, you're an
to,
encyclopedia.
to your point, I want to say that when we look at certain studies, a Horizon trial would be one. If any of you guys want some light reading tonight, this would be the study you would look up. In that study, they showed that patients that had a micro stent plus cataract surgery versus cataract surgery alone. So if they just had cataract surgery, the patients that had the stent plus cataract surgery, there was a 47% reduction in visual field loss per year in those patients. That's a huge number of reduction in visual field loss. And so you're only doing yourself a favor and you're definitely controlling the glaucoma better.
Yeah, I would go so far as to say if you have mild glaucoma and cataract surgery and your doctor doesn't talk to you about having a MIGS procedure, at least talk to you about having a MIGS procedure alongside of it, I would question whether or not you're talking to the right doc.
I agree.
Another question, but that does remind me of another question that I'll ask later. I
Great.
am a 72-year-old woman with advanced glaucoma. My doctor said I can't do any more surgeries and has prescribed expensive eye drops with no generic options. What do you think?
Okay, I'll start with maybe I can. I'm gonna, if that person's still on, I'm gonna ask him a couple more questions. How many
I'm, I,
surgery
yeah, I don't,
is it
I know
possible?
she just recently asked the question, so,
Okay, great. We'll see if she answers, and then we'll go to your other question and come back if she's got an answer.
okay,
How many surgeries have you had, and what types? And
okay.
that'll at least let us make a less incomplete answer. So we'll
And
give
are
her a
you
little
getting
time.
worse? And are you getting worse? Did your doctor say you were getting worse is helpful too?
Yeah, okay,
Okay.
great.
Well,
Okay,
hopefully, if she's listening, she'll answer now.
let's see. Let's see. Okay, go
Okay,
to your
and
next one.
then let me think about what my question was. Oh, so if you're having issues, with your doctor and they're not listening to you or they're not giving you more options, like you've heard of other options, but they're not really open to them, they're not explaining why, what should you do?
Change doctors.
Change
You
doctors.
can start by saying, "Hey, I'm a little concerned here. I would like I've read about these other things. Can you explain them to me?" And if they get gruff or don't have time for you, eject. And then the other thing that I would say is, and there's some patients that we haven't connected. I think it's mostly because they didn't like Justin, probably not me, but um, just kidding. But you have to feel a connection with your doctor. That matters because we're doing real stuff here, and there's got to be a two-way trust. And don't move forward with surgery if you don't feel that trust. Don't do it.
Yeah.
You got to trust your doctor. Get another opinion. But the maybe more common thing that I see is somebody's just scared and they want a second opinion. And my advice to you is get the second opinion. And don't worry about your doctor's feelings. We get yelled at so much in medical school. We oftentimes don't have them. And what I'm really saying is don't don't worry about us. We're going to be okay. It's you that we care about. Almost all of us doctors just want what's best for you. So get a second opinion. And if you don't feel a connection with your doctor, get a different one.
Great advice. I think we have an answer from the previous question, if I'm reading this
Okay.
correctly. She had a trab and laser, and the laser, her surgeries were 10 years ago. She said she had most of the surgeries, but she can't remember all the names.
Okay, got it. So, and did she say if she was getting worse?
I don't see that right now.
Okay. I bet your doctor is doing right by you, is what I'll start with, because I really wanted to hear had you had a trab. That said, there is some data and some progressive options where even in people that have had trabeculectomy before, stents or a goniotomy has shown to lower eye pressure. So if you haven't had a MIGS procedure, you can try it. It doesn't necessarily mean it'll work for sure, but you can try it. They probably have you on expensive glaucoma medications, and my guess is that it's Rocklatan or Ropressa or Vyzulta would be my guess. They're good medications. And they probably are a little bit more effective, and then some people a fair bit more effective. But I generally believe in trying, the generic prostaglandins first because they're less expensive and they're generally well tolerated. These are general things I can't know for sure without actually seeing where you're at, but I want to try to be helpful. So I'll summarize. There might be some MIGS procedures you can do, and you could maybe try a less expensive generic medication. Justin, any additional commentary?
I think you're spot on. Nothing really to add on that.
This is another example of best for your life
Yeah.
because, what might be best for your eye is an expensive branded medication, Vyzulta or Rocklatan or something like that, and they can be expensive. But that might not be best for your life depending on your financial situation. And you got to be comfortable having that conversation with your doctor, and your doctor has to respect it.
Agreed. And another thing is some companies, when you go to this is not everyone knows about it, but I do like to share it when we can. If you go to the company website, sometimes they do have coupons and things like that for patients to use when you go to the pharmacy. Another good option is like GoodRx and those kind of companies. We have a lot more information on our website if you look for financial assistance. So that might be something as well
Yeah, that's great.
if you can't have the generic options.
Totally.
Alrighty. Does one eye's condition affect the other eye? For example, if one is blind in one eye due to trauma decades ago, does that blindness cause glaucoma in the other eye?
No.
At a higher risk, though. It doesn't
Yes.
necessarily cause it, but there's a higher risk of
Well, yeah,
glaucoma.
but if it was from trauma, not just that they had glaucoma in one eye that caused them blind. So
Hmm.
if they had glaucoma that caused them to go blind, then yes, that other eye is at higher risk. But if they got
Yeah,
hit in the eye by a rock, that doesn't increase the risk of the other eye going having glaucoma. But it means it's more important if you do go have glaucoma because you don't have
yeah,
a spare.
yeah.
Thank you. And can you comment on the risks of glaucoma surgery, for example, an 83-year-old woman or at any age? And does age actually relate to treatment options?
Justin, you go first.
Yeah, the type of surgery matters. We have these conversations all day long with people because MIGS procedures, for example, in my opinion, in John's hands, are very safe surgeries. And I tell patients that I feel very comfortable with MIGS procedures, stents, goniotomies. Those to me are very safe surgeries. When we start getting into certain types of a subconjunctival stent, anything with a bleb, trabs, tubes, those are much more aggressive and risky surgeries. I don't take those lightly. And when I talk to patients about them, I let them know that there's real risks and real things can go wrong with those types of surgeries.
And then to answer the question a little bit about how does age factor in, I think it's really an equation for us is how many decades do you have left? And a really healthy 82-year-old is very different than an unhealthy 82-year-old on what we may suggest. And so if you had low pressure glaucoma, we may say we want to do a more aggressive surgery on you because we need to get that pressure lower, or we may add an OPAP. If you had a high eye pressure glaucoma and it was kind of new, we might just start with an SLT. And so there's a really broad spectrum there. But the take home point for this lovely 82-year-old lady is, in general, don't be scared of surgery. Um, if it's a trabeculectomy or a tube shunt, that's a higher stakes surgery, but still don't be scared of it. If you trust your doctor, they're doing the right thing for you.
Thank you. How does blood pressure relate to glaucoma?
Yeah, good question. Um, Low blood pressure has been associated but not shown to be causative of glaucoma. We do pay attention to low blood pressure, especially in normal tension glaucoma. That's where your eye pressure is normal, but you still have the disease and maybe it's still getting worse. There are some doctors that say eat potato chips at night because all that salt is gonna, and they only had to tell me once. Um, because all that salt can raise your blood pressure a little bit. We don't generally recommend that, but it may be that you need to have a blood pressure medication adjustment if your blood pressure is dipping low at night. I actually believe that it's less of a blood flow problem and that a low blood pressure actually leads to a low brain pressure. And so your eye pressure might be good, but your brain pressure is a little low, and that's the problem across the optic nerve. That's not definitively true. That's my belief, and we've got a little data to support that.
Thank you. Um, so I know you mentioned before that when you have advanced glaucoma, you should see a specialist, a glaucoma specialist. Now, where is that line? Because if someone's seeing a regular ophthalmologist or an optometrist, will that person tell them you need to switch, or what should the patient do?
They're the right doctor, they'll tell them when they need to switch or that they'll collaborate with them. And there are some ophthalmologists, like my partner Deb Risfet in Alexandria. She's not glaucoma trained, but she's great at glaucoma. So just because you have a comprehensive ophthalmologist doesn't mean for sure you have to have a glaucoma specialist. You can have a great comprehensive ophthalmologist. And like I mentioned with optometrists, very, very wide variety. To some that say, "Hey, I see glaucoma. I'm just not going to do anything. I'm going to refer you right away." And others that say, "I got you, and I'll collaborate with you and your glaucoma specialist as we need to." So there's not a line. It's really dependent on who your doctor is.
And again, the communication there is important.
Indeed.
Yeah. For those who have lost vision, is there a team member who can help with individualized strategies to maximize remaining vision? For example, low vision specialists or rehabilitation services?
Justin?
Definitely, yeah. So, I mean, many states, I know in the state of South Dakota, we have a service for the visually impaired and service for for the blind, and we utilize it often. They're wonderful. They do an unbelievable job for people that have visual impairments, not just glaucoma, but in our world, it's glaucoma, and so we're working with them, and they will actually in our state come to your home, and they will work with you to make sure that you're able to do the things that you want to do to live a good quality of life. I'm guessing the Glaucoma Research Foundation probably has some tools as well, I suspect.
Yes, we do. Yeah, it's different for each state, but definitely there's different organizations in each state that can help. And it's
I will.
important. Yeah, go ahead.
I was just going to say that these folks are heroes. They are unsung heroes too. Doctors, we get a lot of people that gives us bunt cakes and stuff like that for taking care of them. The services for the blind, they're heroes. And oftentimes the doctors don't think of it. We're
Mhm.
just thinking about how do we treat this disease and not thinking about all that other stuff that's there. And so almost every state. I bet every state has some sort of service like this, and you should plug in and ask your doctor about it. They'll probably know, but you can find out online too.
As you were mentioning before, it's about quality of life, right? Because it's not that you have to go see these low vision institutions at the end. You should see it at the beginning to improve your quality of life.
Right.
Um, do you have any recommendations for dry eye?
Yeah, great. That's a great
Justin,
question. Yeah, great question. That's one thing that is unfortunate with a lot of the things that we do to treat glaucomas. We induce a lot of dry eye, and so it goes to the second piece of what we were talking about earlier. Our number one goal is to prevent vision loss. But number two, that's in the back of our minds all the time, is how do we keep the surface of your eye healthy and happy? And so minimizing drops is number one. There's ways to minimize drops. There's preservative-free drops that we'll utilize. There's now drug delivery devices that can be really implanted that can release medication to kind of hopefully get you off of drops. MIGS procedures that we talked about as well. So minimizing those drops. And then there's a whole other arsenal on the dry eye treatment side, which we won't get into, that we can utilize as well. But my mindset typically is, what can I do to minimize the drop burden? Because usually, and drops are still good, we use them every single day. But when you've been on them a long time and you're on stacked medications, two, three medications, that can be very hard on the ocular surface over time.
I
Thank
have nothing intelligent to add. Justin nailed it.
you. And speaking about medications, so when you have SLT, do patients come off all medications or do they still have to have some eye drops?
Sometimes is really the answer. I think that it's a pretty good rule of thumb that if you're only on one medication and you did SLT, I'd say that there's north of 70% chance you're going to get off that. If you're on two to get off of both of them, that's probably 30 to 40% chance. If you're on three, you're probably not getting off of all of them. But it's really a we're going to do this and then we're going to see how your pressure responds. We're not that great at predicting it. That's why you give percentages, not yes or no's.
Yeah. If someone were to seek, and we only have time for like a few more questions, but if someone were to seek a second opinion, what information should they take with them?
At the very least, your last eye exam and OCT in a visual field. So your last exam, no OCT in a visual field at the very least. I think.
And one other, I would just, sorry, John, I didn't mean to interrupt
Yep.
you. I
No
was just
go.
going to add one really important thing. If you know what your highest eye pressure was before treatment, that can be really, really helpful for us.
And
Hmm.
and then the next thing that I would say, other than the highest eye pressure, is if you can see what the visual fields have done over time.
Hmm.
That's really, really helpful too. So bring those things with you if you can. And by the way, you can. They are your records. We legally have to give them to you. And and even if we didn't legally have to give them to you, we should anyway.
That's right. Okay, we're gonna do three more questions. Is it safe to do yoga or any exercise where your head is down? And are there any other exercises we need to avoid?
I think yes, it is. This is an area of controversy. And the reason I think yes is because your eye pressure goes up dramatically, but so does your intracranial pressure. And your intracranial pressure may even go up more. And so I think that as your eye pressure goes up, your brain pressure goes up to balance it out when you're in a head down position like that. Other exercises to avoid, I don't think so. People have talked about tuba players or trumpet players where their eye pressure goes up, or weightlifters. But when you Valsalva is what's happening there. Valsalva is like kind of blowing out with your nose and your mouth closed,
Mm.
and your eye pressure goes up, no doubt about it, but so does all the other pressures in your body. So I don't ever tell people to avoid any of those things, and I don't tell people to avoid scuba diving. Justin, do you disagree?
I do not disagree, and I think aerobic exercising is actually good for your intraocular pressure. So doing aerobic exercising, getting your heart rate up, not only good for your body, but also for your glaucoma.
Great. Good advice for everyone, huh? All right. Can you comment on the type and extent of damage that the preservative BAK can cause when used long term?
Yes, it
Yeah,
can cause meaningful damage when used long term, not only on the cornea itself, but on the goblet cells and the conjunctiva. Different people have different reactions to this, but it is certainly associated with longer term dryness. I think that we generally feel like 1 or 2 doses of BAK per day are generally okay. Some people it's not. Some can tolerate a little bit more. Justin, do you have additional commentary there?
I would just say it's a love-hate relationship with it because it allows that medication to get where it's supposed to go. And that's what we want. We want that efficacy, but it can cause toxicity to the cornea, and that's what we're trying to avoid. So it's this love-hate relationship with it.
That's a good description. Last question. Is there a center or model of collaborative glaucoma care, for example, in the Chicago area, that patients can look to as an example? And how should patients advocate for better collaborative care?
I don't know who it would be off the top of my head in Chicago. I gotta believe there's plenty. Justin, do you know anybody in particular?
Not at the top of my head.
I'm sure if I had an internet search in 15 minutes, I'd find you something good. I think that it's just pretty straightforward communication. Hey, I really like my eye doctor that I've had for the last 20 years. Are you willing to work with her when you're talking to the glaucoma specialist? And when you're talking with your doctor, you say, "Hey, are you comfortable with this?" And and if it was your eye, would you go to this gal for a glaucoma specialist? And then they say yes, and then it's done. And if
Yeah,
they say no, then you figure out something else.
sounds good. Thank you. Well, thank you both for sharing all your knowledge and showing us what a great team you are. All your knowledge and your energy was fabulous. So thank you. And thank you to all of our participants for your interest and for your support. Remember that all donations made during Glaucoma Awareness Month will support all of our important work here at GRF and will be generously matched by our campaign partner, Bausch& Lomb. But if financial support is unavailable to you, there are additional ways you can help. You can be our champion and advocate. You can share your story with family and friends. You can let your doctors know about Glaucoma Research Foundation and share them with share our excellent patient resources with them. And lastly, share with your friends and family when you talk to them about the importance of regular eye exams and visiting your doctor because everyone's at risk for glaucoma and early detection and treatment are essential to preserving sight. So, thank you once again, everyone, for being here today and for standing with us in our bold vision for a future free from glaucoma. Because of your unwavering support, the cure is truly in sight. Thank you, and until next time.
Thanks, guys.
Thanks, everyone.